update on how things are going. And I must say I've been watching and looking as I'm walking around, social distancing. I think a lot of people seem to be doing their part, and that's great. That Ontarians are stepping up to the task. Even I know some are sort of forget for a moment and step back and do different things. I'm really encouraged by the way that other sectors, media are coming in and giving examples and encouraging everybody to stay the task as we're heading towards nearly our first week through some things and the days. And so it is challenging and it is disruptive for many, and we've seen some aspects, and we'll talk about those in a moment. At the same time, there's the harsh reality that it is a serious event. We've heard another death related to COVID-19 in the Halton area, and that is unfortunate and sad to hear. And of course, our condolences go out to the family and members there, and of course with the staff who are working around there. All the protection steps were taken in that, and we're trying to understand more about that person's exposure and what had occurred in that as public health continues their investigation of that event at this time. So it reminds us that it's not a theoretical issue. These are important issues to pay attention to and to continue our social distancing. So as usual, I'm going to ask Dr. Yaffe to talk about numbers and cases and that, because it gives you a pulse or an idea of how things are going in Ontario, and perhaps some global things as well, if that seems appropriate. So over to you, Dr. Yaffe.
Okay, thank you. So in Ontario, as of this morning, we have a total of 257 cases. Of those, now, unfortunately, 2 are deceased and 5 resolved. This is an increase of 43 from yesterday. And the increase reflects a number of factors, the lab trying to catch up with the backlog and the fact we have more people coming back to Ontario. We also have 30,972 still under investigation, and a total of 12,421 negatives. So as well, we are continuing to test what we call sentinel testing, which is people admitted to hospital with severe respiratory infections, outbreaks in long-term care facilities with respiratory infection. All those are, samples of those are being tested for COVID-19. At this point, almost 1,700 have been tested, and they are all negative, which is wonderful. We do have some still pending investigation. So of those who are confirmed cases, 80 of those where the investigation's been completed, 80% have traveled outside of Canada. And of those, 26% came from some part of Europe, 28% from the United States within the past 14 days prior to symptom onset. And 15% were a close contact of a case. And for the others, the public health investigation is continuing. So within the United States, the most common states were New York, Colorado, California, Florida, Nevada, and Massachusetts. At this point, Europe has had now more cases than China, with over almost 96,000 cases in Europe and over 4,300 deaths. We have been working very hard with our local public health units on investigating all cases, and at this point we're aware of about 22 cases who are actually hospitalized, keeping in mind that this number changes. That, I think, is it for data.
Correct, and we're trying to continue to look at how to keep our data and the information flowing forward, especially as we're dealing with, as Dr. Yaffe alluded to, the number of people returning to Canada, especially from the U.S. We're anticipating, over this time, anywhere from 200,000 to 500,000 or more, in fact, that will be coming back across in there by various means. We've heard some of the issues at the federal level with the border and some of the changes there that we feel will come into effect either today or tomorrow. But we're trying to get the details of who will be allowed and essential things back and forth in that with the agreement between the U.S. and Canadian governments. But that, nevertheless, that speaks to the issue that we've had a lot of people coming back. The lab testing, we're trying to get the backlog. We're glad to say that in that aspect, the federal government has acquired a large volume of test kits, and they are forwarding those large volume to us. So that's less of an issue it was yesterday. And we're still looking, got some more reagent from them, and so we're looking at more of that to come forward. So we hope with that and with our satellite labs kicking into gear, we'll be able to move on any backlog and to move, I guess, fairly expeditiously going forward to try and deal with that and get those up. Because it's important, as we're trying to wrestle with there, we have people who have lab tests done where it would be nice to know what the result is. There's some where it's very important they know what the need is, the results are, and there's some where it's critical they know very quickly what those results are. And we're trying to look at some priority ranking so that as we go through this process, certain settings such as patients admitted to a hospital, seen in emergency departments, people in critical conditions, for clinical and for personal protective equipment protocols, they would need to know as quickly as possible. Also trying to look at how do we test healthcare workers. If there's settings where there's someone who has become ill on the floor and that, we need to know that as quickly as possible. There's some issues related to First Nation communities in remote areas. We need to know that as quickly as possible. So we're looking at a priority list to say, we make sure that they don't get lost in the test pile, if you may, and they can be expeditiously moved through because that doesn't impact our response. And so we're dealing with that. So on wider issues around that, we've also put out a memo from my desk to the healthcare sector on managing healthcare workers and illness and return to work. And so that's gone out because we found there was a variety of things being asked by different institutions and employers to staff, and this was of concern to a number of, including our collaboration table with our labor union members. So we put out a memo to that effect. I'm asking that we would, at this time, stay to the 14 days since returning from their travel, from the time of arrival in Ontario, that they would do so. And of course, if they developed an illness in that time, they would do the same process as everybody else in that, and we can talk about that in a moment. But also they need to take that and notify their employer in occupational health and safety and public health to be assessed in that situation. And then following that, the return, they would have to consult with public health as well as with occupational health and safety at their institution to have the all clear to return to work at that stage. We also said in there, because there was some concerns that during this time, if things get really critical, there may be some staff positions that an institution says, we really need to have these people, we need to have them back. And I said, you can do that ahead of time to designate which positions in your mind are essential, and with discussion with all parties that they would mutually agree that these ones could be essential, and someone, say, on their 12th or 10th, 11th, 12th day could return to work, assuming they have been asymptomatic up to then, and with some extra some protection, say, on the job, and monitoring could do so. But those are ones that we would like to have those positions determined prior to that event occurring, while we have, at least at the moment, a window of opportunity to do that. It is busy work, something has to be done, but I think it's necessary to avoid confusion at that time. So that's gone out. We've also then sent a memo, or going to come out shortly from my desk, asking acute care hospitals to do the same rigorous screening of visitors as long-term care facilities and retirement homes. We've asked them to undertake that as well. And so we hope to have that out shortly in there, and so that same as your long-term care facilities, if you've traveled recently in the last 14 days outside of Canada, or if you've been in contact with a case in the 14 days, within 14 days, we ask that you'll be turned away and not asked to visit. If you're ill, of course, that's always been the position, you should not be visiting at that time. At the same time, we know there may be some ethical reasons why someone, say, with a loved one would like to be allowed in because there may be time of death and there's unfortunate circumstances. They would have to negotiate that with the facility to see what kind of protection they'd have to wear, time of visit, etc. So we're not saying outright that no one under any circumstances can't, but they would have to assess that situation in the facility in their own prerogative and make a determination, being sensitive and empathetic to the unique challenges of that visitor. in that circumstance. So we're sending out, we're trying to review our wider list of who are essential workers and who should be in that regard. We haven't put out a comprehensive list. I know even at the Special Advisory Committee at the national level, had to leave the teleconference early. There was a desire, can they compile a national list that we'd all agree upon? And that's, all sectors are working on this one here, who is essential and who should be allowed to go back to work prior to the 14 days in there, assuming they're asymptomatic and being monitored with some proper protection, because some people are basically in a cubicle 6 feet away from everybody. Does it really matter if they're in that position? So the unique circumstances that employers would like to negotiate with the employee if it seemed essential and critical to that person be on the job. So overall, I think we're doing well. People are working at it. They're doing creative things. I like the idea that for children and family, it's a family time. There's family activities, looking at virtual type things they can do. People are actually doing a lot more exercise, walking outside and that on your own, of course, not in a large cluster and group. And the weather is improving somewhat and getting warmer, and so that might encourage some more outdoor with social distancing, if you may. I watch the behavior in the stores. I was interested in hearing on the media I guess it's called someone gave a version of the two-step dance around with the cashier. I thought that was very interesting, and I've seen that actually occurring to some extent. So I think Ontarians are really embracing this. I think by doing this steadily over the next number of days ahead of us, as these returnees come back, as they go through their 14-day period, and with the border closing that, there will be a period when that kind of inflow will have ended to some extent and mostly, and their time of quarantine will be over, and we'll have to assess things at that stage. So that's why we hope to keep informing Ontarians, how are we doing? The fact that we went back up to 45, as you remember Tuesday, you said, am I encouraged by only 9? And we said, I don't think I'm going to take that as a realistic number. And the 25 was probably more realistic. I think 45 is not surprising to me with a number of people coming back. I wouldn't be surprised if that climbed up higher to 50 or 60, just because if our system is as robust as it is with picking up and people reporting and the numbers and volumes we're dealing with, it would not be surprising to me, and in one sense be reassuring that our ongoing monitoring is still working well in that regard. So that's our situation here. We've had some questions, I should mention, on our big outstanding issue besides the lab testing is PPE, and PPE in all sectors. We have people working full-time, full-out on acquiring orders, maintaining historical orders, going for new orders, working with their federal counterparts. As they did, they came to, they delivered on the swabs in good time, 800,000 kits. And how else can we get some of the other aspects in there? And so we're driving on that. Now there's a matter of priority. Who should get which PPE at which time, which is the most priority setting? And we've talked with many sectors, including our labor groups, and saying maybe have to sit at the table and decide what is the priority in that. And we have people in healthcare, we have ancillary services attached to healthcare, and it gets further and further out. And then we got sometimes people not in healthcare that say they want to have it because they feel they need it. And when the data doesn't really support that, how do you do that, and how do you ascertain? So if there's lots around for everybody anytime, I guess you can do what you want. But we're not in that situation, so we have to make sure that those that need the most protection get the most protection so they can do their job, and we don't put them at any hazard, because the vibrancy and the performance of our healthcare sector is very critical in these next weeks coming up. So those are the main things I wanted to talk about today, and we're open to questions.
We assume that a worst-case scenario has been drafted. What is that worst-case scenario? How many deaths possibly, and how many waves?
Right, and you're going to ask the famous question on modeling. I said the other day, modeling is a really good tool to look at scenario design. And one of the aspects there is that you have to analyze what are the assumptions, what are the rates of infection. There's all sorts of details that goes into it. It's a mathematical projection. And it's assumed that there's been an introduction to a naive area and something's happening. There may be some built-in immunity at times, there may not be. We're assuming in this case, because it's a pandemic, there's no built-in immunity within the community, if you may. And it comes in as an event and it starts to work its way through. And you've heard numbers like 70 to 80% of the people will be infected. And they project that. And because they do a turnaround and saying every 4 to 5 days it doubles. And you can see how it goes almost exponentially after a while. And so if you do that, you take the numbers in Ontario, 13 million, you put 60, 80%, you can do your own quick math in your head. It's not unusual, they would say, well, very quickly, within a period of your first case, if you already have community-wide spread throughout the community that's already occurring, that you have not been aware of, within a period of 3 to 4 weeks, you would already be at 10 to 20,000 cases. And of those 10 to 20,000, there's about 20% that would be hospitalized. And within those, of the whole population, there'd be mortality rate right now is varied. It's usually around 2 to 3%. Italy, it's much higher, unfortunately. And you'd say, well, then there's a lot of hospitalizations, and deaths, I should say. That was the deaths. So you should see that. So one of your tests of what's that is that if that's the case, then we should see evidence of not just 45 a day. We should see 3 to 4 to 5 to 700 every day rolling up. We should be rapidly moving up to 10 to 20,000. In some cases where we've had before, when we started in the end of January, we should have seen that by mid-February. We should see the hospitals already being loaded in ED departments. We should see not just 22 people, we should see a lot more. And we should have not just 2 deaths, unfortunately we have 2 already, we should see a lot more. So one of the aspects of the model says, okay, where are you at? You take the theoretical and put it into the real data and say, is there a match or not? If it isn't, why isn't it? And that's the question we want to ask to say, because that tells you, is what you're doing, is it working or not working? And most of the time you're only talking about one event. But the way we are, Canada, and Toronto especially, and the GTA, in this global reality, we don't have just one community here, we have multiple. And so we went through, and because our issue with China, Wuhan, and Hubei province is that we had 5,000 people a day going back and forth, all through December, all through January, all through March and February. March, it dropped down, I'm wrong. We should have seen, because it already was, we had our first case in January, but they're already ramping up big time in China in December, very big time in November. And so why didn't we see? And then that calmed down. And then we had the whole event with Iran and Italy. And even the people didn't know exactly when it started. And the country didn't announce the 19th, although people said it was already happening a week before that. We had people going back and forth. We have one of the largest communities here outside of the country. Significant movement. And the people weren't advised. They didn't know. So we should have seen it again. Now we have another challenge. And so we're not fortunate to have only one event that's going to impact us. We're moving through each event. And our public health units, with our containment thing, have done an immense amount of fantastic work tracking all these people down, contacting, phoning contacts. And it's just a huge amount of work. And especially some of the large ones initially, like Toronto and around the GTA, have had the majority of the work to do. And that's no end to the amount of workforce involvement and hours of calling and correcting. I think that's kept us intact for the first 2. Can we continue? And that's our challenge. That's why we said we can't just depend on that alone. We have to have the social distancing. We have to declare an emergency. We have to close the schools and that, because that kind of number coming back, I myself, I can't say that public health alone can hold that line on that totally. We just don't have that kind of workforce in there. But if we put these checks and balances in place, if we ask people, and people adhere to isolation, if people adhere to social distancing, that 14-day period, and still assessing cases, and there will be some more sick patients, and there will be hospitalizations, hopefully not many deaths. We'll have to see how we do. And as I said, we had our first 2 weeks. Now we have another 2 weeks. We're not through my second 2 weeks, I said a week ago. We're coming to there. I said high precaution, added to very caution. And now we're going to see, because everybody locked down, basically. Schools closed 12th into the 13th. People didn't go on March breaks. Some still did. People started returning writ large on the weekend into early Monday, Tuesday. We're trying to get some data from CBSA, Border Security. How many are coming back? What's the flow in that? How's it happening? So we're in that critical time right now. and those people having, if they've been exposed, because assume they're coming back asymptomatic, they're not ill because they won't be able to come back. Assuming that they come back, knowing there's a period of time when they incubate, average, it's usually sometime around 7 to 9 days after the last exposure, if they are incubating at all. And so if you took that and you do the math, you're looking at, okay, when would this might likely peak? We seen the same thing at Trenton, the people off the Diamond, Princess, and one was symptomatic on flight. And now we have the 10, and a lot of them occurred after about 6 or 7 days, 8 days in the quarantine process. So it seems to be consistent, especially with that average demographic age group. And so that gives you an idea of the numbers we're talking about and how we're going to monitor it. So worst case scenario always is that if it goes, you haven't been able to contain it, your social distancing hasn't been able to limit it, and it goes widespread, and those numbers start to ramp up. And I mean, the worst case we're hearing right now, unfortunately, and the challenges are huge in northern Italy. I mean, it's just amazing how they're going to do it. I don't know. It's just overwhelming. And so we don't want that situation. I don't think we will. But one should not be too overconfident. But I am confident in our system. I'm confident in our containment processes. I'm confident in the Ontarians' response. And I'm confident that people coming back will be responsible and will do what they're supposed to do, just for their period of time, 14 days. So I think we can pull it. I think Ontario, we can do it again.
So then how was Premier Jason Kenney able to give a projection today that Alberta is going to peak in 4 to 5 weeks?
I haven't seen their modeling. I've seen the numbers. Of course, their number of cases is a lot lower than ours.
Could we give a projection here?
Well, they just started with their cases just about, their first case was a week and a half ago, 1 or 2, and so they're just starting to ramp up now. So their situation is very different than ours. Their movement of people is very different than ours. Their demographics are different than ours. Their global situation with the international airports is quite different than ours. So, and the number of border crossings and the flow is quite different. So I don't purport to know what one, I haven't really asked their CMH, I haven't asked her how she did the calculation or what model they used.
Projection in Ontario?
Well, we've been told by our modelers that saying that once your introduction, as I walked you through, on the premise that's community-wide, you'll see a peak, they always say, by the repetitive time, in about 3 to 4 weeks. It's not, and we should have seen it in February, we should have seen it in March, and you do 3 to 4 weeks from when this whole thing started with that aspect there. That started about 2 weeks ago. So we should be seeing something. And the fact we got 45 today, that still seems to me surprisingly low with the flow we've got coming, but I will be not surprised that goes up. I don't want it to go up huge, so we'll have to watch. Sorry, it was a long answer, but.
Speaking of modeling, there's a sort of draft ongoing study by researchers at U of T, UHN, and Sunnybrook that has said that Ontario will reach its capacity of ICU beds in 16 to 37 days, depending on the spread rate. Have you seen that, and is it reliable?
I haven't seen that study per se, but if you base it on the modeling and the cases, and what I've told you with those 10, 20, 30,000 number, that would not be unsurprising. That's where we're looking quickly, how do you deal with it? Because it's droplet spread. So an isolation room can be any room that's used for isolation. It's more important what you're doing in the room. And that means we're ordering more ventilators. We're trying to acquire quickly even more ventilators. That seems to be, if you're in the Italy situation, the limiting factor. So some people in isolation room are just watched and monitored with nasal oxygen. They're still in isolation. You're going to have, if everybody has COVID-19, you can put more than one person in the room if you want. I don't recommend it, but you have to do what you have to do. And we're looking at different, if we had more facilities, where could we get them from? And as you heard, the minister said she's looking into that, and we're looking into that. So we're not going to say we're just going to hope we get it, we do it. We're going to plan for it in case we have to.
If I could just add, I think it's important to keep in mind, it's very helpful to have these modeling papers and discussions. They're based on assumptions, and the assumptions are the best they can be at the time. Things change. And they help us to plan for services. So that is why, we're asking to cut back on elective procedures, they're ordering more ventilators and so on. But at the end of the day, they are modeling, and they may or may not reflect what happens.
Follow up on that, is one of the assumptions the existence or the extent of community spread right now? And how, you've spoken at this at length, but how do you know the extent of it? How do you not know, especially considering the testing gap, the inability to do so many tests?
So, we talk about community cases. That means you find one that public health, to the best of their ability of asking and interviewing, can find any connection to travel or to a known case contact. Now, we know by infectious disease things, it just doesn't happen spontaneously. They got it from somewhere. The assumption is they might have got it from someone we don't know in the community. Ideally, what you do, as we do in infectious disease aspects all the time, we find out that person's circle, then you find out there's 4 or 5 other people symptomatic. Then you find attached to those, there's another 20, there's another 30. You can see that there's waves of infection that are already out there. And after a while, I said, I don't know how far it's gone. It's gone in our community-wide. Now, maybe community-wide in pick a community, but not in Northern Ontario. Because it doesn't go, it spreads by waves and contact. It is droplet contact in that aspect. So it has that, and then every 4 to 6 days, it doubles. If you find out that you missed it and it's gone and gone and gone. If that's happening, you would have to assume if it's gone out and that one has a background of, say, 200 or 300 cases, some of those should be going to the ED departments. Some of those should be seen. Some of those should be picked up in our sentinel surveillance because they came in with respiratory problems. And even if they say we weren't looking for it, we say we found it. And so that's why we're doing the sentinel surveillance also. Is it totally 100% proof? No, it doesn't mean it happened. So my challenge always in that one there is that I want to see evidence of community-wide spread, much like we've done with other infectious disease outbreaks, where we know we try to do a cluster, local, either in a facility, local as in a group or in an employment site, and you do that investigation. But you sometimes find it's just gone out. And as we check more, it's more and more, and now it's gone community-wide. I would like that demonstrated before I say it's gone community-wide. Now that means a lot of work, but it's something you have to do and you always have to be going looking for. So I would call local spread. So you have a case and you assume if the person can't recall, and it's pretty hard to remember what you did in the last 14 days. You might have met someone that you didn't know and sometimes later you said, do you know that person was a COVID-19 case? I didn't know. No one told me. I told public health I didn't know anybody. And they didn't. But that can happen. And they may not recall that moment, but they'll call back later, just like we had one from Iran who had been back for a while and said, someone called me up and said, you're in contact with the case. The person didn't know. As soon as they knew, they went and got seen. And so how does one do that? So we have local clustering, and then you have community-wide, and that may be that community, but not the next one. And so can you contain it within that community, much like China did with Wuhan, and then they expand out to Hubei province, right? So was that a successful endeavor? It would seem to be, so far from their data from their other cities, that the cases they had in other large centers were all travel people from Wuhan. So their process seemed to have been successful. They had community-wide in Wuhan. That's a lot of people. But it was not community-wide throughout all of China. If you see it, just there.
I'm just wondering, how can you be sure that something hasn't been missed and is lurking? I'm speaking of this because of a note put out by Ottawa's Medical Officer of Health yesterday, Vera Etches. Testing isn't able to track down each case in our community because the mild illness the majority of people experience is not distinguishable from common colds, and we cannot test large numbers. So I'm asking that because you've already said that going back to the case, the original cases and the spreading models or the projections, it should have happened in February, maybe it should be happening at the end of March. We haven't had any of that yet. So are we just really lucky, or is maybe something lurking?
I would say that, I agree with what Dr. Etches said, that, as we know, 80% of cases are mild. In fact, some people might even not realize they have anything, and we have been telling people, you don't need to go to the doctor if you're not feeling really sick. You don't necessarily need to get tested. And as Dr. Williams said, we are trying to prioritize the test to healthcare workers, people in long-term care facilities, and so on. So what we're trying to focus in on is the most ill and the people who could give it to the most vulnerable. But, you know, I think we're, you know, I wouldn't say we're lucky. I'd say that what we're doing is focusing the efforts on the most important people and most important cases. And we're very pleased with the excellent compliance of the public with social distancing. We're just talking about being the 4th largest city in North America, and if you go out, it's almost like a ghost town. And so I think people are really acting very responsibly, and we're working together as a community to do everything that we can to control this infection.
Just to follow up, I've heard yesterday some people, they're leaving their shoes at the front door, like outside, because they've heard the virus can come into the house on shoes. Whenever they get home from where they've been, they take off their outside clothes and put on their inside clothes. Is that going too far, or is that a good idea? Because we know about surfaces.
Yeah, it doesn't stay that long. You've heard other consultants say generally it's about 1 to 2 hours. And the chance that you stepped on something and then walk for another 2 or 3 hours, is it still going to be there? Not likely. I guess my mother told me to take my shoes off anyways when I go in the house. That's just proper etiquette in our family, I guess. But that's another whole issue. I think the clothes, that means you've been leaning and brushing against all sorts of stuff. I don't recommend you do that. That and different things. Now should have an overcoat, and you may want to take care of that. But the chance of carrying it on, and if you take a 1 or 2 hour commute back, is it still going to be unlikely in there? But there's a lot of variables that can play in there: temperature, humidity, what was the source of it, etc. So, is it precautionary? It's precautionary. It may be extensive, but people, I think, feel they want to do what they feel is necessary. The same as some people want to still wear masks around the city, even though they're not anywhere near 6 feet of anybody. They're using very determined hand hygiene, so they're using layer upon layer of protection because that's what they feel they want to do. And I don't. Okay, that's what they need to do. I'm more interested in the social distancing and the staying at home and all those aspects there. So I think let's keep at it. And we're doing well, as Barbara said, Dr. Yaffe said, and I think that's excellent. But you have to stay the course now. We're only for some it's only day 4 and 5 for Monday since the emergency, but some are since last week with the children at home. So it's not, we have to focus our minds on being consistent and keeping at it and planning ahead. What are the things you're going to do, activities and things to keep all that, connecting electronically and do all those kind of socialize. So people are distancing but more connected, it seems, in some ways. And it's good to see in that way. And that's one of the advantages we have now, we didn't have before, is there are lots of media and ways to do that without having to be right with the person.
Okay, we have to move to the phone.
Sorry,
Sorry, it's already one question and that's it.
It's about the death in Halton, the one that was announced today. I know you've been careful not to say there is community spread, but they've said that this man had no contact with anyone who had COVID-19 and no travel history. So is this a case of community spread out in Halton?
I've had several conversations with the medical officer of health from Halton today about the case, and what I learned from her was that so far they have not identified a connection with travel or a case, but they were still doing the investigation.
Okay, thanks. We're going to move to the phone lines. Just remember to not have your phone on speaker. One question, one follow-up.
Your first question on the phone comes from Allison Martell, Reuters. Please go ahead.
Thank you. So I know that you're working on resupplying protective equipment. Can you tell me, has the province distributed any personal protective equipment to hospitals or other providers so far?
I think I heard it. We're continuing to complete orders of historical past. So that means what they normally order, those we have been understood are still being delivered. But with the amount of concerns in that, they're going through some of it quicker. And so we're looking at how to ramp up that delivery to them. But regular deliveries, we understand, have been occurring in the large institutions. There's some smaller ones that probably their orders do not come forward on a regular basis because they're not using it on a frequent one, and they've already run out sometimes, and they're making requests to us on a regular basis, many, to say we need some, we're out of it, we want some, and we're trying to, as best we can, address those needs.
Okay, one follow-up.
So has the ministry been able to place any orders so far?
Then I guess you're asking, has we been able to place any extraordinary orders? We've placed a number of orders. Have they been delivered? Some have, some haven't. It varies because those companies are in a large global situation. And of course, we've been in communication with a national procurement on behalf of the federal government that would do it on regards to all the provinces and territories, and they're doing their part as well. So everybody's doing and looking for it wherever they can get it from, and we have been successful in some levels, but not as much as we'd like to be, and we're still driving at it.
Okay, next question.
Your next question comes from Emma McIntosh with National Observer. Please go ahead.
Hi, we've heard from the parents of a medically fragile teenager who needs 24-hour care, and they've told us that Public Health Ontario has not recommended that nurses and personal support workers, in his case, use masks, gloves, and gowns. I'm just wondering what the current guidance is on this, and if it's different for home care versus like a group care setting like a hospital.
If it's the one that I was aware of, there's a mother of a child with some serious medical issues, and certainly I sympathize with their concerns. My understanding is that the worker would be wearing appropriate personal protective equipment. The child does not need to wear any. And the concern that I had heard was that she wanted the child to wear PPE. So we're saying that the worker should be wearing PPE, and if they aren't, the mother should be contacting the agency.
Follow-up.
If there are shortages in this area and these workers aren't able to get protection, would you consider bringing expired protection back into rotation?
I think that had to deal with some areas have run out and their equipment is expired. Would that be the correct context?
Mm-hmm.
Thank you. We have looked into that matter. The issue being, while some people feel theoretically it's okay, the manufacturers have not come forward and agreed with that, and neither has the licensor in Health Canada agreed to that. So while you could try that, the risk is that if they did become infected with COVID-19, whether it's from you at the time they're wearing or not, there would be an issue to say, well, you were using expired equipment that the provider, the manufacturer, did not agree that you should be using.
Next question.
Your next question comes from Sean Jeffords with the Canadian Press. Please go ahead.
Dr. Yaffe, I'm wondering if you can elaborate a little bit more on the 22 people who you mentioned were hospitalized with COVID-19 in the province. I guess I'm wondering if that number takes into account all the cases from the start of tracking on this, or is this a current figure now? And what does that mean overall in terms of how the hospital system is handling this illness?
This is information that I've received. I've asked the health units to notify me on a daily basis about any hospitalized cases, any other unusual circumstances, and of course, any unfortunate deaths. So as of today, my understanding is there are 22 cases in hospital. Now, again, there's a proviso that they may not be aware of all of them, and they may be discharged as we speak, or they may be new ones. So it's a moving target. As far as we know, the hospital capacity issues are not significant. They have been working on reducing elective surgery and opening up more beds. So I don't think this has caused any undue pressure on the system at this point, but certainly the system is preparing for that.
Follow-up.
One on community transmission. I know that you mentioned that this individual who unfortunately passed away today, it's too early, I guess, to say whether this is a case of community transmission or not. do you have any sense of how long it actually will take to track this back?
Well, it's, as you know, a case in Halton, and the health unit has to do the investigation, interview the patient's family. Obviously, the patient cannot be interviewed at this point, to find out where he had been in the last 14 days before he became ill. And that might not be that easy to find out. He was admitted a few days before he passed away. And, where was he working? Did he socialize? Like, what was he doing? So it's hard to say, probably it'll take a few days, and they may or may not be able to determine where he got it.
Next question.
Your final question on the phone comes from Jenny Yen with the Toronto Sun. Please go ahead.
Hi there. The ministry has set out guidelines for weddings and funerals that are exempt from having a maximum of 50 people. Is it not irresponsible to have that exemption given that people are urged to do social distancing, for example, not even having a friend over to a house?
My understanding is that we said they're still called gatherings, and they had that limit of the 50 on there. There may be ways that you could arrange, I'd say more with the funeral, you could have it in sections with visitation and things that you could end up having more than 50 over the whole event. So there might be ways you can structure things that way that would be within the sensitivities of the ceremony, and yet honoring that situation. So we were still holding to that would be the rule. I hadn't heard any definite exemptions. We haven't been asked to look at that. In particular, we were more asked to say, would that meet that category? I guess one could imagine a large outdoor one, not in this weather maybe, wedding where people are spread over a large field and stuff. I guess there could be something, but I think it's more people gathered together and honoring that with the 2 meter distance throughout the whole thing in the bride and groom. I guess there's challenges in there, but I think they can honor that because they're going to be close contacts anyway. So.
Thank you. Mike, if you have a question.
Sorry, I apologize. I was working. Growth rate of new cases. So I've been tracking it over the last 8 days and the last 4 days. It seems like in the last 4 days you're looking at about a 15% daily increase in the number of cases. Some researchers have just put out researchers at UHN and Sunnybrook and U of T have put out a scenario about hospital capacity with a growth rate of 7.5% per day. Mm-hmm. Do you have a target of what the social distancing measures could do to the growth rate? Because is it conceivable that you can get below a 7.5% per day growth rate?
Well, I'd like to think we can. I mean, you were in the room, but we had talked at length about modeling and the arithmetic and working that, and how already we've had 2 major impacts into our area here where we should have already been way over, and we didn't. And I think that was the containment activities of the public health units. Now we have those containment activities continuing, but we've added in social distancing and we've added in emergency measures to do that, to assist. Why? Because this time the amount coming back is quite huge, potentially, back from the U.S. And we don't know the full extent of the spread of the infection in the United States. It's evolving fairly quickly. And so while we might have thought that where most of our people are coming from the eastern seaboard would have been exempt, it may not be the case, so we have to assume that aspect. Do I think that by people given the right information? I was pleased to hear that someone came across the border last night, was asked questions, was given a pamphlet, was told what to do, and was given a fact sheet. We didn't see that a week ago. And that is more assertive action put out by the federal government with their CBSA guards at the border crossings is reassuring. And people are listening to that, and we're trying to ramp up our other methods with our self-assessment tool and different ones like that to try and engage the concerned public as much as possible in every way so that they not only will be informed of what they should do, but also have some of their questions and concerns answered. And that's why we're trying to ramp up telehealth, all those things that we say to put in place. It's not just social distancing, it's not only aggressively following the cases and their contacts that we talked about, but it's also keeping the public informed and with communication and answer their specific questions about their specific circumstances, that if they're unsure what to do, they would get advised of what they should do. And so that they would come forward in a timely way or take the proper steps to continue isolating, continue social distancing until such time, because it is droplet spread, it is containable if everybody does what they're supposed to do. And therein lies the challenge.
Follow up, just really brief.
This is the last question.
Okay. Do you have a target for what you think the growth rate could be reduced to? What is that target if social distancing measures are kept in place for the coming weeks?
Well, we have been saying, and now with the extra swabs coming from the federal government, we hope our reagents and our labs continually expanding, because we said 2 weeks ago that in 2 to 3 weeks we hope to expand and go up to a capacity of 5,000 tests a day.
No, I'm talking about the growth rate of new cases, sorry.
Well, part of that is the testing. and so how do you document those? If the growth rate of cases goes up considerably and they're still home isolating and they're not getting ill and they're doing what they need to do and it limits the impact on the EDs and impacts on the hospitals, that would be successful. As I said, right from the get-go, our target is, first, try and keep mortality down. Look at your vulnerable population. Second, keep your morbidity down. Why? You don't want to overwhelm your healthcare system, right? And so if you can keep mortality and morbidity down, even if you have a number of cases, if they do all they're supposed to do and stay home and do things like that, a lot of them cases, Dr. Yaffe already said, when you're out of the room, are going to be fairly mild in that 80%. It's the vulnerable population we're worried about. And part of our aspect is to deal with that. And so if you get a lot of people under that who come back and have mild symptoms and report in and stay at home and do the things they're supposed to do, and then after 14 days are cleared, and there's a large number of those, would that be a failure in the system? I would think that shows the success of containment through social distancing.
Okay, that's all we have time for. Thank you.
Thank you.